Generally speaking, I have found that cataract is more of a diagnosis of exclusion rather than inclusion. What I mean is that these patients who are presumed to have cataract have to be evaluated well for any other disease which can be compromising their vision. This is one patient who came to us with cataract in both the eyes, and the person or the lady wanted surgery in the right eye. However, when examined, I could see that there is a macular hole in the right eye, which was actually the culprit or responsible for severe vision loss in this eye. This is the OCT of the same patient, which demonstrates and confirms the presence of this macular hole. And so this patient was counseled that there will not be any significant visual gain with the cataract surgery in this eye. And this is the other eye where we can see there is a similar cataract. This is the fundus, which shows a nearly normal fundus with no macular hole, and this is the OCT to confirm the same. So this patient was planned for the cataract surgery in the other eye, that is the left eye, in contrast to what the patient desired. The patient was agreeable and the surgery was executed for the left eye. And this is the point where we start seeing that surgery. As we can see, this is more of a immature cataract with significant glow which is present, and there are vacuoles in the nucleus which are responsible for that perception of polyopia as described in the texts. So overall, it is very important to evaluate the fundus of each and every given cataract case, so that any other disease which can be contributing to the vision loss and assumed to be because of cataract by both the patient and the doctor can be excluded. I have frequently seen situations where patient had ARMD, patient had retinal detachments, patient had macular holes like this, and diabetic retinopathy, where the doctor and the patient both might have assumed that this is because of senile cataract changes, the vision loss is there. However, if you don't exclude these diseases and simply go ahead and remove the cataract, then you have a disappointed patient and a surprise for the operating surgeon when these diseases are diagnosed. However, in presence of mature cataract, it is not possible that one can accurately evaluate the fundus. And in these scenarios, it is useful to have a view of the other eye, which will give you some clue about those diseases which are commonly bilateral, like diabetic retinopathy, age-related macular degeneration, and similar other diseases. In spite of all these evaluations, it is always possible that patients may have disease which is hidden behind a white, mature, dense cataract, and they are just not visible to us. In that scenario, an ultrasound B scan should be done to exclude presence of media haze like vitreous hemorrhage or vitreous opacities and presence of retinal detachment. B scan cannot exclude diseases like ARMD, diabetic retinopathy, or presence or absence of macular hole. However, this is best you can do in an effort to exclude all possible surprises after the cataract surgery. This particular case, the surgery is not very special. It is a very routine and effortless cataract surgery which involves a grade 2 nucleus and which can be simply chopped and removed using phacoemulsification. The patients in these scenarios have a surprise because when they visit the OPD, they are expecting surgery planned for the desired eye. However, if patients are counseled properly, more so they should be counseled about the possibilities that not only the proposed surgery, which includes the retinal management, also is going to be pretty expensive, as the results are not going to be as good, because in spite of managing retinal issues, the recovery in the vision is usually not as good as a patient who has normal retina. So I usually have a strategy that I counsel these patients that they should undergo a surgery which involves the operating the first eye, which is a nearly normal eye or in which the retina is fine, so that their handicap is taken care of. Basically, making them understand that they are here to get their handicap because of the cataract cured, and if we are able to get that done, patient's lifestyle improves. However, if we operate the eye which has a retinal disease, although it can be managed, but still recovery will not be as good, so they should not get that eye operated. In that scenario, patients usually understand this well, and I have found that they can agree to get their eye operated, which will promise them a better visual gain. The other eye or the diseased eye which has retinal disease as well can always be operated later on, and you will always have a satisfied patient whose problems you have addressed well and the handicap is taken care of. Most of the patients are not very disappointed, rather they tend to understand that this advice is being given for their betterment. Here I can see that the cataract surgery has been done, the IOL has been implanted, and now viscoelastic gel is being removed. The surgery has been finished without any event. This is the day 1 post-op picture, and we can appreciate this is a good outcome and patient was thoroughly happy with the outcome. The other eye is being proposed to be planted after a month of this surgery. Thank you.